the 4th International Scientific and Delegates Conference of the Global Association of Clinical Officers and Physician Associates, held in the heart of Gaborone, Botswana. Yesterday we had a very beautiful opening ceremony. We had very important guests pass through to give us very heartwarming and inspiring speeches. Yesterday we had the Deputy Speaker of the Parliament grace this occasion. We had the Country Director of WHO grace this occasion as well. And then we had senior members around the world also gracing this occasion. Today promises to be a very insightful session. We will have a lot of scientific presentations. We will have another involving panel discussion to do. We will talk about the global strategic impact for GACOPA. We will talk about a lot today. So those of our colleagues who are not here, if you can just text them to hurry up so that we can start, because this day is packed. We need to get through it quickly so that people can retire and go rest. My name remains Joe Padu. I am the chief moderator for this important gathering. Yes. So I would want the media team. Can I get a microphone? Media team, can I get a microphone? I would want just three people from each row. You just tell me what they took away from what we did yesterday. So one from here, one from here, one from here. I don't want to point to anyone. So just do now. So the whole room, look through yourselves and appoint someone. Media team, can I get a microphone? Okay, so I'll start with this row. This row. If you don't look at me, I'll point you. This row. If you don't look at me, I'll point you. Somebody looking deep down. Yes. You have a savior on that row.
Thank you so much. This is also good from Kenya. And one thing I do from yesterday's conversation is that for anything that will happen, you really need to work with the government. Because when it comes to policies, you cannot push your own policy, but you want the government to hold your hand for that policy to be pushed forward. So working with the government on the day is important for us to achieve anything from here, today, and tomorrow. Thank you.
Thank you very much. Please put your hands together for him. Put your hands together for him. Now someone should just tell us their takeaways from yesterday's happenings. Someone wants to speak, or I would have to point someone.
Pick the lady.
We should pick a lady, huh? Okay. My guy says you should pick a lady, so one of the ladies from yesterday. The lady in orange on the second to last row.
That was Kenya. Another country that is not Kenya.
Because all the ladies on that row are Kenyans. So if you are going to be gender, I mean, okay.
Oh,
so no, she was not here yesterday. So we have to pick one of these two. And Sylvia, yes. Tell us what you learned yesterday.
Yes.
Tell us what.
Oh, you want me to speak?
Yes, speak.
I took the microphone so that I don't speak. I give other people a chance to speak.
Don't worry.
Okay, thank you so much. What I learned yesterday is that as a region, we need to segregate ourselves in regions to pull all of us together in terms of developing the career of clinical officers and physician associates. I also learned that there is more that these countries need to learn. And when I just did my small survey online, I found that most of our African countries are lagging behind in terms of embracing clinical medicine, and they are the ones with the worst doctor-patient ratio. And it actually tells us something that we are a little bit ignorant, and we should work to make sure that we embrace the politicians to embrace the idea of training clinical officers and registering them and making sure that our patients get the best service possible. So every government, a clinical officer fraternity through GACOPA and other associations hereby, we should lobby our politicians within ourselves and in the parliaments to promote clinical medicine. Otherwise, I also learned that most of the Gaborone citizens are a little bit shy. I'm actually finding it difficult to know where the Gaborone citizens can't really point out. They're a little bit withdrawn. I don't know why. They should come forward and take the stage and be vibrant enough on the platform. But I like their cheer. They always talk of Pula. Pula. You see, the voice doesn't resonate with the value of the Pula. Pula. You see. Maybe the third time, maybe they will be a little bit vocal. Pula. You see. And when I talk about Kenyans, sasa nitasema nini? Harambee. You see, those are the locals here now. Harambee once more. Those are the locals.
It's okay. We'll retry the Pula after breakfast. We'll retry the Pula after breakfast. Maybe by then.
Oh, Pula hasn't gotten breakfast. Yes. Maybe.
So the last row, can someone tell us what they took away from the conference yesterday?
Good morning.
Good morning.
What I took away yesterday is that nobody will come for us. We have to be ourselves to sell ourselves. And I would say, like somebody who is about to retire, nobody came to hold me up. I hold myself up. So I urge the young clinicians here, don't wait. Stand up and go.
Thank you. Please help me. Okay, I think that's a holistic recap of what we did yesterday. Yes, so today, like I've mentioned earlier, promises to be a very insightful session. And I want to add up to what Xavier said. When you look at the health systems across Africa, no one would have to tell you that clinical officers and physician associates are the backbone of the primary health care we render to our constituents. But take a look all over Africa, you would see that these are the people who sometimes have to fight before they even get employed. Sometimes I sit and wonder that who did this to us? Because we are in a health workforce that needs the clinical officers. We need the physician associates. But these people are at home and are unemployed. And they are people who are ailing and they need these clinical officers to take care of them. Then there is that disconnect. What happened to us? What happened to universal health coverage? If we keep continuing like this, are we ever going to achieve that? Because the clinical officers will go to areas where other health cadres will not go. The PAs will go to areas where other health cadres will not go. Let me tell you, when you come to Ghana, there are about 1,512 health centers that oversee 5,000 plus CHIPS compounds. When we say CHIPS compounds, they are community health posts. And these health centers are manned by physician assistants. So indirectly or directly, physician assistants are overseeing about 5,000 CHIPS compounds in the country. And the number of people that these CHIPS compounds serve in every community, when you collect them, they are about more than half of the population of Ghana. And these people are taken care of by the physician assistants. But to go to Ghana now, there are about 3,500 plus physician assistants waiting at home to be employed for about 4 years now. Why that? Go to other countries. The story is similar, if not the same. That is why we have our Legislative Health Assemblies Forum here today. We are going to discuss all of these issues. The lawmakers must stand up and be counted. They are the ones who bring out the policies that will employ these people directly. We don't have to go and fight to render care to save our people. It should be a no-brainer. When I start talking about these things, I get emotional, so I think I'll pause that here. Yes, before I start delving into areas I shouldn't go to. So this morning we have a very important person in our midst to deliver our first keynote address of the day. And he's in the person of, I have a long list here, I have to go through all of that before that person comes. It's a very important person. He's in the person of Engineer David Ochola. He's the chair of the Migori County Public Service Board. He holds a BSc in Electrical and Electronic Engineering from University of Nairobi, Kenya. He has a Master of Arts in Project Planning and Management from the University of Nairobi. He has a Master of Science in Renewable Energy Studies from Moi University, Kenya. He's a registered professional engineer with Engineers Board of Kenya, who has served previously as an engineer with Kenya Power Limited, Lake Turkana, Wind Power, Radiant Solar Energy in Eldoret. Engineer currently serves as the chairperson of the Migori County Public Service. Ladies and gentlemen, with a resounding welcome applause, let us welcome Engineer David Ochola to take the stage to deliver his keynote address. Please give it up for him.
Distinguished guests, ladies and gentlemen. Good morning, everyone. Thank you very much. That's all to do about me. First, allow me to register my apology for having not been here yesterday. I had a lot of meetings running concurrently. So I spoke to the president on the sideline so that I can excuse myself to attend to some other meetings with my governor. Other items back at home. Nonetheless, I want to appreciate the organizers of this meeting, particularly the president post, whom I happen to support. So he has to conduct himself very well, otherwise he can have coming back to glory party on his fire. We don't want to have some kind of situations. For me. I'm not sure if this is audible enough. Maybe I can use this. The other one as well will restrict me so that I do not do a lot of movement. So the technical team will allow me to maybe to use this one. We all look so good, and I want to thank the Botswana team for being a great host. How I wish that I should also partner with the GACOPA, that every year I just make my technical appearance and also drink from the wisdom and knowledge which comes from this kind of an association. I really want to appreciate you. But Botswana is a beautiful, beautiful country. Yesterday evening I was just driving around the city to see how beautiful it is. We can stay here. Maybe we can extend Austin. We stay for another 1 week and enjoy the delicacies of the Botswana. Nonetheless, I was invited here purposely to speak on matters relating to the public service. And in every county, every country, so to say, you have the body mandated to deal with the human resource management, because all of us work in the health sector, but then there is that one person, there is that one body who deals with the human resource management. We are lucky, probably maybe Kenya, South Africa, Zimbabwe, Uganda, who have implemented the aspect of devolution, where the structure is a devolved system administration. When he was doing the introduction, my friend from Ghana, I don't know where he has disappeared. He mentioned that I come from Migori County. Let me just give a brief about that. The Constitution of Kenya 2010 devolved the system of administration in the country. And I think thereafter some other countries as well also copied. I think Zimbabwe implemented their devolved system of government from 2013 onward. Uganda has been doing some devolved government using the local government. I don't know how many local governments are there in Uganda. Are they 5 or 4? The East Central. The Ugandans are in the house? Yes. How many are they? Yes. $175 of those devolved units. South Africa, my friend Taban, is he in the house? Yeah? 9 provinces. So those are devolved units. Similarly, to Kenya, we have 47 devolved units of government. I come from the 44th. The 044, which is county 044, which is Migori. Migori is just at the border of Kenya and Tanzania. When you're driving through, or you just use your Google Map, the very moment you are from Tarime at the Sirare border, you're just in Migori, so in that kind of area. With a population of about 1 million people living in that county, but a registered number of voters is between 400,000 to 500,000 as per the last voting system. So rural government is effective, it is working, but not all the units were devolved. There are other units which remains with the national government, which probably will also find in some of these countries which we are in. Particularly like if you talk of the Department of Security, security is still being managed by the national government. It is not a devolved unit. But health, which we are talking about today, someone has been paid to finish me politically. Health, being a devolved function, is purely managed by the public service at the local government level, or what we call the county level. That's why you see in your program is the theme we are talking about is the role of County Public Service Board. I just want you to relate them with the role of the public service in that evolved function in your province, that evolved function in your local government. That's what works with it. It's more or less the same even if it is being done with a universal one. Allow me to wait for the technical team to set up so that I can. are sure of that.
This is unfair. This is very unfair.
From Migori County, where I come from, Kisii, Trans Nzoia, Bungoma, Nairobi.
No, you can't be in two places.
How many are from team?
question that, was this really, really necessary for this presentation here in Botswana? My answer to you, yes, ladies and gentlemen, it is, because as probably I was listening around, as you were told yesterday, you have to fight for your right. You have to work with the government of the day. Whatever you do has to be implemented. At one point, you will realize that the key implementers of those things are those public service commissions. Probably most, if not majority of you who works in the government setup, you will realize that when you are employed, particularly the big number from Kenya, either you are employed through the county public service boards or you are employed through the public service commission. Who is the SR? That's where you pick your letter. If anything happens that disciplinary process has to be done, then that disciplinary process has to be done through that the same body where you got your letter. So that HR has to come here, not as a police, but just so that we can have a very good working relation as an employer and employee. Because when you work in an environment whereby it is so toxic and you're not able to deliver because your employer is ever on your back, I can tell you without a doubt that you will not have proper service delivery. So as we talk of good service delivery, there must exist a good working relation between the employer and the employee. And that's why you need this fundamental key thing of the human resource aspect in this conference. But why do we need it? It's affect the quality of goods and services which we are producing. The very moment when you have employees who are not responsive, whatever you're producing will not be good. It's a driving force. That HR aspect is responsible for the managing other resources of an organization, is a prerequisite for all our organizations. The employees are very scarce. My brother from Ghana here said that they remove or release a lot of clinical medicine officers, and then it takes 4 years down the line, 5 years down the line, they have not been absorbed. That character is not only in Ghana only, it cuts across Africa as well. It cuts across Kenya. Right now you ask anybody from maybe Tanzania or even from Uganda, the number of people who are still tamaking, the number of people who are just there and probably are not employed. So you have to get the best resources for them, for you to work with them in this sector. Now, what are our specific roles as employer? I need to just give you a brief. Though some of these things are well enshrined within the constitutions, if you are well versed with those provisions of the constitution, like the Mheshimiwa here, who are being guided by the constitution every day. Even us, as we discharge our mandate, the constitution has to guide us. The key functionality of public service commissions is to establish an office. You know, when you're working, Prof, you sit down with the departments and realize that you need to set up a certain office. For that office to be created, it has to be created through the Public Service Commission. For the devolved function, we have to create that through the county public service boards of creating new offices. We just check what is the need, what do the people need? Is it really necessary? It is really important. So one of the key fundamental functionality which we have as a public service is the creation of a new office. Like, for example, we can sit down with the leadership of the clinical officers and they tell us, look, Chairman, we want to create an office here of assistant clinical officers. Probably it is not existing in the scheme of service, but then it has to be created. And the process of creating it is a procedure through the constitution. That position has to be created. You have to take it to the parliament or to the assembly if it is a local county government, so that the assembly can approve it. Once the assembly has approved it, even before it goes to the assembly, there must be a committee on labor and relations which has to look at it. Is it really necessary? And how is it going to affect the wage bill of that county before it is even created? So one of the key mandates which we have as we talk of service delivery is the creation of new offices within our public service. That becomes one of our key functions. Number two, we deal with the vacancy management. We are the employers. Every now and again, the employment we can do external or internal. Right now, we tend to prefer doing the internal because when you do internal advertisement, you give that lady a chance to move from one job group to the other. You give that person a chance to move from where he or she is to the next level. But normally, because the Constitution says, or the procedure says that any position must be done competitively. So even if it is internal or external, the competitiveness must be there, whereby competitively means that position must be advertised and people has to apply, the shortlisting process must be done, and then you call people for the interview. A very key role which we all undertake, and all of you knows very well that probably that's what you also underwent for you probably to be in the office where you are today. It is our role. I don't like talking about the next functionality which we do. Most of our employees fears these things, and they normally look at us as people who are bad because we do disciplinary control. We, ladies and gentlemen, as public service or as boards, we are not after anyone. You know, we operate in situations whereby if somebody just sees the chairman passing, people just want to hide because you are performing the function of a disciplinary control. Nobody will simply come for you if you're doing the right thing. The very moment you're doing the right thing, Mheshimiwa, there is no one at all who will come for you. But it is our role as a public service commission, it is our role as county public service boards to exercise disciplinary controls. Because these things, if you are not well managed, you will end up having a lot of issues in our health sector. A very good example, which is well known, is absenteeism. A situation where you have a clinical officer, a clinical associate, the physician, they come to, like this lady said that you come from Kisii, right? You report to Kisii level 5 hospital, that's where you're employed to work. The County Public Service Board of Kisii, which was previously chaired by Elijah, who is today is the deputy governor, knows that you're supposed to report to work. At the same time, you report to duty for only 2 hours. Then you sneak and go and run your private function somewhere. Are we being fair? You know very well it is not being fair. So that is where now the County Public Service Board and the Public Service Commissions come in. And when you come along, people will run away from you saying that, no, these people are after us. Let's just do the right thing. Nobody will come after you. So those matters of absenteeism, you work in hospital and you realize that even the very, very people who are working there are the ones who are sneaking or even helping or colluding with others to steal the drugs and facilities which are there. How I wish that at the end of this conference, we live with our heads high, with a lot of ethics, knowing very well that if you're employed to do something, we need to do it. So matters of absenteeism, matters of drug theft, matters of intoxication, a clinical officer coming to work while so much intoxicated. I was one time told, Prof, that how can you prove intoxication in a court of law? You have taken an employee that, you see, we are giving this employee a summary dismissal, reason being he was intoxicated. How do you prove that in a court of law? You want to do alcohol blood test? No. You want to provide a video? No. So the lawyers in the house will just weigh you down. It's a big thing to deal with, and it's one thing you cannot challenge somebody when you find that person that is toxic, and you cannot even sack that person. You cannot sack that person because of intoxication. Because how do you want to prove it in court? So how I pray that in our midst, we do not have clinical officers who report to work intoxicated. I'm lowering my voice on this. I'm not stopping. It's a huge thing, but it's something we are battling in hospital facilities. Because the president told me to speak about service delivery in our health facility, I have to speak with a lot of authority that if at all we have anyone in this conference who probably promote matters of intoxication in our health facility, whether you come from Ghana, whether you come from Nigeria, whether you come from Botswana here, please let's make our health facilities good places to work, whereby even if patients come, they will see a very sober clinical officer attending to them. It's something we take seriously, and this is one of the things which makes employees run away when they see us. So we are not police, but we just want you to do the right thing. Now this is very good. This is a good thing. This is good for you. And I'll speak loud about this one. For us to have effective service delivery, and I want to thank the Kenya Constitution because this one is established in the Constitution. The public service boards and I saw a huge number here from Kenya. If it is not happening in your county, or if it is not happening in your country, please ensure that this is implemented. The implementation of the values and the principles of good governance is fundamental. And the values and principle of good governance is something which is very easy to implement. They are smaller things, but we are mandated as County Public Service Board, we are mandated as Public Service Commission to ensure that it is fully achieved. You just do simple things. At the end of the year, at the end of the month, at the end of the quarter, take the departmental employees for a team building somewhere. Speak about the issues of the department. Speak about the matters affecting employees. Speak about the issues of their welfares, so that you achieve those values and principles of good governance, whereby you can now be able to deal with employees who report and then they leave. Because if you do not nurture the relationship between the employer and employee, you will not be able to have proper service delivery. And you will agree with me that you can't. You cannot. So this, one of the things which I was asked, that what are we doing, or what is our role as a Public Service Commission to ensure proper service delivery? We must ensure that our hospitals, we must ensure that our facilities, there is proper implementation of values and good governance in all those facilities. If it is not happening, please, you can take these notes and refer to the specific provisions of those constitution, which requires the Public Service Board to ensure that there is implementation of values and good governance in those facilities. It's something which is very easy. Call them for those end-year parties. Talk about the issues. It's not only the honorable members of parliament who needs to have end-year parties. For them, they will do it. But you will end up in a department or in a facility whereby you take 2 years, you take 3 years, you have never even had a departmental meeting. In our midst here, probably we have leaders who head these facilities. One of the takeaways which I want to challenge us is, for you to ensure that you have proper values of good governance, call departmental meetings, even on a monthly basis. Do stock taking. How does your return? How are your returns of your employees? Do you know that you can be running a facility, you are the head, and one of your employees has never been seen in that facility even for 2 months? Because you do not run departmental meetings, you do not run weekly meetings, you do not run monthly meetings, so that you review the issues which are affecting your department. That will help you to achieve the values and the principles of good governance. This is critical. This is critical. We also play a key role in the formulation and development of the various policies. And one of the key policies which is guiding us and which is very key to the clinical associates and the clinical officers and the physicians in the house is a promotion. If I just ask a random question here, we have employees who have been in the system 5 years down the line, 6 years down the line, they have never known what promotion is all about. And it is so much skewed. It's so much unfair. But if you have a proper policy developed by the county public service boards, if you have a proper policy developed by the Public Service Commission, that thing is well structured. Previously, before I joined the county government, I used to work for a parastatal in Kenya, which is called the Kenya Power. And I used to sit at the leadership role, whereby it is very structured. Structured in the sense that promotions are based on appraisals. And it is based on appraisal that as long as you've achieved 3 very goods in your appraisals, you are deemed to be promoted. That means every year we carry out appraisals for employees. My brother, I'll leave for you this thing. Someone is giving me signal mismatch there. And you don't understand. Or it is a battery. Thank you. So when you have a policy guiding matters of promotion, it becomes very clear you will not have a kind of a skewed promotion which is being done on favoritism. This is something which happens mostly in Public Service Commission. And how I want us, thank you. if you do not have a policy guiding matters of promotions for the employees, you will end up with an employee who was employed last year, and there is one who has been in the system for about 3 or 4 years and has never been promoted. And this person will come, will be promoted, and will become your boss. Not that the person is having better papers than you have, but because of favoritism, because he or she is in good books with the bosses. Those kind of things is what weighs the service delivery. You can imagine if you're sitting down there and someone whom you trained, because when these employees come, we subject them to induction and training at the initial stage. The very moment when they come at the induction and the training, you train someone, then the person you train is being promoted and you're there. Do you think you're going to have proper service delivery? No, let's just talk. Is it still there? You will be so much demoralized. So the only solution, Mr. President, so to say, have a proper policy which can be implemented. So as Public Service Commission, as county public service boards, our core mandate is to formulate and implement all these policies. And this is what we are rolling out today in County 044, whereby the policies, we advise departmental human resource managers that they have to adhere to the policies the way we have put them. They give us the appraisal forms. We see how they did the grading. Did the person meet the threshold of going into the next job group? Because if it is not well done, we are not going to have proper service delivery in our counties. So this is a key role which touches on you. Similarly, we must develop policies to deal with the training. There has been problem on who goes on training, who is to be bonded, who needs to be given a scholarship by the county, so that who needs to be given training by the government. Without a proper policy, so those policies will guide us on all those things how we need to conduct those trainings. Recently, we developed a policy in our county for the volunteers and the interns, because the government just send them, or you end up even having interns from other cadres, for the medical, like medical doctors, pharmacists, and all that. In our country, theirs is very direct, being managed by the national government, Ministry of Health. They finish the university and then they're being sent to all those facilities for an internship of 1 year. But then what happened to the clinical officers? What happened to the nurses? What happened to these other cadres who are not well structured? The development of that internship policy must come in handy so that we know, even when you are picking it, do we have proper balance and the equity for all of them? And what is the duration? Is there any stipend for them? Where do you get all those money? Because somebody is coming there to learn, yes, but it's just fair for the interns to be given maybe a token of appreciation at the end of the month. So all those ones we have to do, because the very moment you have them is what will make them even to concentrate. And it all goes along with our curriculum development, the CPDs, which is so necessary, because if this clinical officers needs to be regulated. The licensing body will not renew your license if you've not achieved the minimum required CPDs. That's true. Okay? What did I just do? Okay. We were somewhere here. Okay. We were here. Do you have anybody from the licensing bodies, either from Kenya, Ghana, South Africa, licensing the clinical officers here? You're here. Now, you're here for? In Zambia. You understand very well that if your member has not achieved the required number of the professional development, you will not renew the license. That should be the rule. And it cuts across. But if as a county public service or as a public service commission, we do not provide opportunity for these employees to gain the required CPDs, it means we are doing a disservice to them. Because you cannot put them all through in a system working without any training which can give them those CPDs. Sometimes it's just good. You talk to the government of the day. We normally talk to the government of the day and tell them we are releasing these employees to go for training, and these trainings are having this number of CPDs so that it helps you in your licensing. You can renew your licenses with those kind of trainings which we have. The conflict of interest, I did mention it. We just need to remain ethical act. There is a policy on conflict of interest. You know very well, if you're employed by the government, work for the government, the very moment we find you that you're also running your own clinic somewhere, well, it is good, but during your official working hours when you need to be at work, please be at work so that you're not found on the matter of conflict of interest. So this is one of the policies which we have also developed. We have also mentioned something about development of coherent, integrated human resource planning and budgeting for the personal immunities in all our counties. Let me speak something about the integrated human resource planning. This is an automated system. We try to automate the systems in health. Like right now, we are rolling out an automated system in our county 044, whereby if you want to go for leave, you just press a button and on SAP. You want to apply for maybe any allowances, you do it online. You don't need to come with paperwork so that we minimize. We just want to make that there is proper service delivery for all those things. But there is a problem here on this gentleman, which I did underline, the wage bill threshold. As far as you're doing planning, and that's why my brother from Ghana was talking of much unemployment. It is true, we have unemployment. In Kenya, we have a threshold of 35%. The wage bill must not exceed the 35% of the GDP or the budget of that county, or the budget of that county, I mean the local government where you come from. And that wage bill, when you sit down and you look at the wage bill and the emoluments of all the employees we have, sometimes you realize that there is a serious need in our facilities, but your wage bill is at the threshold of maybe 34.7. So sometimes it forces you as a board or as a public service commission to push some of these things to the next financial year. But it is so sad. You walk into the hospitals, you walk to those facilities and you see people suffering. But on the other hand, you say that if I bring on board 20 clinical officers, my wage bill is going to shoot. The very moment it also shoots, the Auditor General is also in on your neck. The very moment you shoot the wage bill, the Parliament of Kenya is also on your neck. You will be called for questioning at the Senate, and you answer a question that why did you exceed the wage bill of 35? So it's a tough balancing act, which we do, trying to balance the number of people you require, the number of people you need to have, vis-a-vis the wage bill which is existing there. Of course, we advise, and we advise even the Salaries Remuneration Commission on matters of payment, on matters of salary increase. We do performance management system, we do staff promotions and redesignation, among many other things. On the salaries and remuneration, these ones, do we have members of the union here? Very good. No, these are our friends. We are friends today, but these people are not good. These people can push you to the wall. You refuse, huh? As an employer, from where I sit as an employer, one of the person you do not want to meet always is members of the union. You know what? We sign what we call a collective bargaining agreement with them. But the problem comes when you want to implement that CBA, that collective bargaining agreement, because they will come with the tough conditions, which I agree with you. From where you sit there, I agree with the conditions which they are putting on those CBA, because they are fighting for the rights of their members. They want the members' welfare to be well taken care of. They want a very structured way that members have allowances, hardship allowances. Recently, the KMPDU Honorable came to me and told me that they even want mortgage to be included and car loans in their CBA. Mortgage and car loans. And you look at the wage bill, it is really costing. So, on the salaries and remuneration, we discuss a lot. We sign CBAs with the union members, and it is good that you are here, so that this is helping us in service delivery in the health sector. How I pray that when we go back, gentlemen, you make it a bit lighter because of the matters of wage bill. In as much as make it a bit lighter for me, so that as we discuss and look at the welfares of the members, and again, the welfares of members must be cut. I'm not saying that we do not want to sign the wage bills, those CBAs. We must sign the CBAs because those are legal institutions, those are registered unions, and you represent the voice of all these people sitting here. We must sit down with you and agree what is working and what is not working. so that it is a structured. Is it a 2-year plan? Is it a 3-year plan? And how do we want to achieve it? The very moment as a board or the very moment as a commission we fail to implement those CBAs, these people are on the street. So I have a tough scope. 1, signing that CBA. 2, ensuring it is fully implemented. And if it is not implemented, the service delivery in our facilities will go down. You know that. So you ask, what is the role of the County Public Service Board doing? The signing and implementation of that CBA becomes a key mandate which we are doing with the labor unions and the regulatory bodies. And I want to thank the regulatory bodies who are here. Please help us. We are having, hello everyone. Are we still together? I want to plead with the regulatory bodies. Please do a thorough check when you are registering your members. I'm currently dealing with a situation of quacks, in quote. People who brings for you certificates from here and there, and they tell you, you know what? I went to Botho University and I studied clinical medicine. And they didn't even step in that classroom. They were not even there. And then they come to you with a license from a clinical council of Kenya that they are registered. How do you want to start questions? Somebody already has given you and is having a license. And is carrying a license from the Clinical Officers Council of Kenya that, you know, I'm registered. Now, when you start tracing back, you realize that this person dropped school in from 1 term 1. This person dropped school in from 2 term 2 somewhere, and then found his or her way somewhere and got some certificates. But that person is registered. Number 2, the licensing bodies and the union, you can also help us in doing this so that we have proper service delivery in our facilities. Please make your system a bit online. You know, when we're doing recruiting or when we're dealing with the vacancy management, we really have minimal time to do the checks and balances. When somebody gives you license, if this system can be automated to a point whereby he gives me his or her name and the license number, I can simply log into the system and search the name immediately. Most of the regulatory bodies have done that. He did mention that I'm registered with Engineers of Kenya. I give you my license number and you will simply find my name there on the system. So for all bodies probably who are not yet there, in our countries, let's push so that those things are implemented. It gives the employer an easy time to do the checks when we are doing this regulatory. So this is one of the key things we are playing there. And I'll not wind up by not talking about some of the key challenges we are having. In 2001, all the nations in this Africa state, or Africa continent, signed what we call Abuja Declaration in Nigeria. And the 2001 Abuja Declaration was so profound that every member state who signed that document was supposed to commit 15% of their budget to the health sector. Ladies and gentlemen, I can tell you as a matter of fact, none of these countries is implementing this thing. None. This is a report from the World Health Organization, which was showing that some countries on track, Mauritius, Eritrea, they're on track. There's some countries making progress, Gabon, Liberia, Mozambique, Guinea, Algeria, blah, blah, blah. Now, the lower cadre, the countries with insufficient progress are the host. The host, are you there? Our host, are you there? Please, I hope you will not block me at the airport because I've mentioned that you're not making progress. You'll allow me to take off easily. Insufficient, and you can see, this is where you will also find Kenya. Insufficient because there was a declaration to have a 15% commitment on the health sector. I mean, the 15% of the annual budget needs to go to the health sector, which is not happening. How I wish the union members, you can easily pick out that Abuja Declaration of 2001 and push the honorable members so that this thing is really implemented. The government needs to do its part because for us to have proper service delivery in our facilities, the Abuja Declaration must be adhered to and implemented fully. Honorable member, are we still together? Thank you very much. So this is one of the key challenges. That's why none of these people have hit the 15% threshold which was there. Of course, we have major challenges with the critical health infrastructure, the governance issues, particularly on the devolve and the national government. There's still no clear formulation in some other countries. There's a major problem on issues dealing with the supply chain and the procurement issues, which I don't want to talk about. Corruption is cutting across, is a global menace. My main focus is the human resource problems, because that's what I deal with. I do not want to carry somebody's problem. Let me talk of my issues which are affecting me. I'm struggling and battling the issues of staffing in our stalls. I'm struggling with the issues of brain drain. And this is so much prevalent in Kenya. And you know very well, you train them. I'm just wondering. And that's why we are putting a lot of strictness even on our training policy. You know what these people do? You give them proper training. And after 1 year from training, they have disappeared for greener pastures. You've spent a lot of money and you've taken your time. And you remember that time when they went for the training, either you decided to put them on half-pay salary or you just gave them some kind of leeway so that they can go for the training. But they just finished training. You will not find them there. You will find them in UK, and you know this very well. You will find them in Canada. So you go to the facilities, they are not there, but you trained this clinical officer, you've trained your personnel. So you ask yourself, what should we do so that we retain them? The retention formula. What is our retention policy so that all these people, once you even train them, they can remain there and offer service delivery to your people? You are mentioning something. I pay them well. We pay them well so that they can be trained, so that you do not have that brain drain. So these are my problems. I'm dealing with the working conditions where some bosses feel bosses. You know, as employees, we spend the better much of our hours where we are working, in our facilities. You look at the number of hours you spend where you're working. It's much more than the number of hours you spend in your family. You spend in your houses. But you can imagine if you have a toxic working environment, it reaches morning, you simply do not feel like even going to work, because you just remember that, I'm going to meet that boss. I'm going to meet that man. Toxic working environments. So when you have those kind of deplorable working conditions, these are my problems which I'm dealing with as a HR, which I need to see how to deal with. Matters of welfare issues, the stagnation, the CBAs, etc. All these are my problems. But sometimes I ask myself a question, that why are rich countries rich and poor countries still remain poor? Somebody want to give me an answer? No, it was my question. It was my question. I keep asking myself, why do we still struggle all these years? The rich countries become rich, the poor countries remain poor. Very simple things which I've learned a number of times through my traveling, through my learning, that we just need to do simple things. Simple things. I've, with time, done some analysis and I've come to the conclusion that the following principles are what is really guiding us. Ethics. Ethics. They will remain rich or remain poor because either they are not following the ethics or they are following the ethics. You go probably to those poor countries, people are just blatantly ignoring the ethical things they need to do. Someone needs to know, somebody knows very well that he or she needs to be at work, but that person refuses to go to work. No apology, no permission anywhere. Ethics. Somebody driving on the road, he's seeing that the robots are saying red, stop, stop, but the person will drive. Ethics. Integrity. You're working in a health facility and you know very well that your integrity requires you that you uphold some values, but you choose not to do it. For those people who are rich, they are there to the integrity. Responsibility. the respect to the laws, respect to the rights of other citizens, you love your work, strive for saving and investment, the will of super action, and then the punctuality. I don't want to mention names. We said this meeting was supposed to start here at 8. Have you seen when some people are coming? Hello? I'm not mentioning names. I'm just asking a question. Now, if you invest in employees, you'll have proper service delivery, because this is why we came here. If you have employees and you've invested the values of investing in them, we'll be able to deal with the global health security. And of course, our economy will grow. Because when you have employees who are working, your economy will really move. Now, some of these employees who are working there, and all of us, what employees just expect from us as employers, they expect us to give them work that enables them to learn and grow. Work that is personally stimulating, and a workplace that is really, really enjoyable. A comprehensive benefit, which he did mention, that this is what can really, really help them in retaining them. And this is one way how to deal with the brain drain, so that we do not have employees working. Give them proper flexible working schedule. Do not put people working extra hours and you do not pay them, even for those overtime. You do not pay them extraneous allowances. It's just not good. It's not right. Work that is worthwhile to the society, of course, increment in compensation and paid vacations. I'm not sure if in any country you have employers who pay for your vacations. Anybody who can give me? Zambia? Yeah? Paid? None. Yeah, but it's a wish list. A wish list. How I wish the union members, you can also include this one day when we're doing the negotiations, so we see. So then how do we want to do enhanced service delivery? As a summarize, is some of the things which we have just mentioned. I've mentioned about the training and retaining the healthcare personnel, implementing comprehensive retaining program for all of them, developing the training policies, and implement those strict barriers for the bondings and the trainings. They are not necessary. And then the last one, which is in green, introduce incentives as better salaries, compensations, and those career development. These people will not go anywhere. The very moment you employ and give them these services, no employee will leave. Nobody. Even me, if you put me on such kind of a structure, I will not leave going anywhere. I will not leave. And the training, we do training at various levels. Somebody cannot just put you there so that you wait for the training at the tail end of it. You train the employees when they are newly hired. The existing staff need to occasionally train. Yeah, there must be refresher trainings on all those equipment. Like right now, we are in a modern world. People use technologies and those machines. Give them refresher trainings on those equipments which you are having. And those trainings can either be formal or informal. Organize them anywhere for an employee. I charge you today in the name of the Lord, when you leave this place, please go and bang the doors of your employers and public service commissions to offer these things. Because we are talking about service delivery. And that's why we came for a conference in Gaborone, so that we are empowered. I am empowered because this is what is needed. You need this for you to have proper service delivery, so that you request for these things and they're done in your ways. Retention, I've talked loudly about these things. We need to have proper compensation, the maintenance program, the process of providing the full career counseling and safety and health. You know, when somebody is intoxicated, you know you have a staff who is intoxicated. You cannot simply just remove that staff from the payroll. There are a lot of processes you need to go. You will be asked a very simple question. If this person takes you through the judicial review, that which steps did you take even to rehabilitate that employee before removing him from the payroll that is intoxicated? Did you try guidance and counseling? Did you do some nurturing? So we have to inculcate that even as in our work, that those are some of the things which we usually implement. And the HR planning, I've talked about the human resource planning, which we need to check that we have proper human resource planning. You check the health versus the needs. How is the future? This one helps us even when we're doing the recruitment plans, and whether they meet the target, the demand of the area, the human resource to the population ratio, the service targets which you specify. The details of this, I'll share this presentation so that you can check it. That's our human resource planning, the strategic HR planning, how you want to attract employees and retaining them, how developing the policies and retaining them, which we have mentioned here. Okay. The employer-employee relation, I've mentioned about it. The policy development, those are now the things which we must do. Number 5, the vacancy management, which I've also mentioned. Then number 6, as I come to the end, I also mentioned about the CBA management and the measures which needs to be taken by the regulating bodies on these issues. And the second last, there is something here called equity plan and 2/3 gender rule. In our countries, I know Kenya exists, Uganda probably. Do we also implement 2/3 gender rule? You do? You do? Let's strive to avoid a situation whereby you are in a department and the 2/3 gender rule is not being implemented. We are facing facilities whereby you go to a facility and it's a male-dominated. You go to a facility, it's a female-dominated. The 2/3 gender rule and equity plan. Now the equity plan, for some of us who come from Kenya, it's enshrined in the constitution, whereby when we are doing employment, we must ensure, because Kenya is such a country with about 43, 44 tribes, the equity plan, you have to represent all the faces from all those regions. If you're doing recruitment in Gaborone, then it means you have to pick all from all the regions which are represented in that area. Not that you're only picking one person or picking people from one particular sub-tribe which is existing there. Equity plan. If equity plan is not well implemented, you will not have proper service delivery in your health facility. And the last one which I call upon us, for all the clinical associates and the medicines and clinical officers who are here, please, when you go back, bang the doors of your employer so that you have the implementation of proper scheme of service. One of the problems which we are facing is implementation of proper scheme of service, where somebody is a graduate, is holding a degree in clinical medicine, but is being employed in a job group J or another job group which needs to be employed by somebody who has done a diploma. That kind of mismatch, I don't know if it's happening somewhere else, but where it is coming from, where you are coming from, please ensure that you have proper implementation of scheme of service. What I'm sharing here is the revised scheme of service for the Kenya, which we are currently implementing. For the Kenyan team, if it is not already implemented in your county, go to County Public Service Commission and tell them to start implementing this new revised scheme of service for the clinical officers, the clinical associates, all of them. This is the latest one. Because if you're holding a degree, you have no duty to be paid the job of somebody who has done diploma. If you've done diploma, then you need to be compensated at that level. If you have masters, it's well categorized. So that news, the scheme of service, we are lagging behind and people are not motivated because we are not implementing proper scheme of service in our health facilities. Allow me to end here, and I want to challenge the leadership of GACOPA that you need to make this a universal movement. It will take you far. You will rock and roll. Make this a universal movement. Thank you. But I remember this one you can even get, I can share the scheme, the revised scheme of service. You can help in the implementation of this one because you sit in the health committee. There's a revised scheme of service for the clinical officers in Kenya, and if you will realize that most of the counties are not implementing it. So help them. For us, at least, it's something we have picked. The president came to my office with a huge document with a delegation that, Chairman, this thing you have to implement. So I have no option because your president comes from, so he sits there every now and then again, came with a document that we have to implement these things. So you can push this one as well. I was just mentioning that let's make this a universal movement so that we can have even a universal scheme of service whereby a clinical officer in Zambia, an associate or a physician in South Africa can work comfortably in Kenya, can work comfortably in Uganda, can work comfortably in UK, so that you have a universal scheme of service. You are recognized all over. How I wish you bang the doors of those international labor organizations of Atwoli and the team, so that this your movement is well recognized and we move places with this. From where we sit, from the Public Service Commission, from the employer, you have our full support. And some of the things I did mention here, for people who come from my county 044, be sure they will be implemented, be sure we'll take care of them. But because we also sit in a forum with all the chairpersons of all those other counties, 47 of them, we discuss these things when we sit down. If yours is not implemented, talk to the chair or just raise it up so that I bring it up in our meetings there so that all of us feel at home. Up to that end, may God bless you. Thank you so much.
Thank you so much, Engineer David Ochola, the chairman of the Migori County Public Service Board. I invited him here as one of the keynote speakers, considering that back home in Kenya, they are the people who employ us. So such a forum was needed here. And I want to congratulate him and acknowledge him for being the first county to implement the new career progression guidelines for clinical officers. That is putting the clinical officers at job group J for diploma and L for degree, so that an intern who is a clinical officer is paid at job group H. So it puts a very big difference between a clinical officer and those other cadres. As clinical officers, we've done 3 diplomas. Diploma in clinical medicine, surgery, and community health. Those other cadres have got only 1 diploma, and we also do internship. So that is the reason why the General Secretary of the Kenya Union of Clinical Officers pushed so that we have that career progression guideline, the first of its kind for any of the 17 cadres in the Republic of Kenya. No cadre has got a career progression guideline except the clinical officers. So those who are going to be employed by the Migori County Public Service Board, there's an advert that was done, they'll be employed at job group J and not H. And they'll take 1 year and then they move to K. That is now the reason why we need such forums. So I want to invite the Secretary General of GACOPA to continue with the program. And we will be having interactive session. There is the legislative part of the forum, where we'll be having around 11 honorable members that will be chaired by the Honorable Dr. Pukose, who is the chair of the Health Committee, National Assembly of Kenya. Thank you.
Thank you. Okay. Thank you very much, Mr. President. And thank you, Engineer David Ochola, for that eye-opening presentation. We are grateful. Yes. So at this point, we are going to move straight into the sciences, abstract presentations. We are going to get our first abstract presentation. I want to know, is Sylvester Ogutu around? Sylvester Ogutu is here. Okay. So Sylvester Ogutu will be presenting the first abstract titled Innovative Approaches in Clinical Officer Practice for Enhanced Patient Outcomes. That is the first abstract we are going to get from Sylvester Ogutu. So, Mr. Sylvester, if you're ready, if the media team is ready for you. Okay. So, the second abstract will be by Scott Smalley, The Benefits and Limitations of Establishing the PA and PA Comparable Education and Profession Globally with Focus on Africa. Then we would have the presentation by Honorable Dr. Fred Mavizi. The Legislative Health Assemblies Forum will happen. And then we would have other abstract presentations So, Mr. Sylvester, if you are ready now, please let's put your hands together for Mr. Sylvester Ogutu.
Okay, thank you so much. This is Sylvester Okumo Ogutu from Kenya, and I'm going to present an abstract here. I think the technical team, we are ready to go. Yes, sir. From the onset of this, I want to say that this is a project that was actually, we have partners who supported this project, and this is just the part one of the 5-year project by Jaramogi University, which is my mother university, and then partners from Belgium who are actually playing a role when it comes to partnership and networking in terms of NCD management in lower and middle income countries. So I want to make a presentation here on the innovative approaches in clinical officers practice that will actually enhance the patient outcome. Okay, thank you so much. NCDs are chronic conditions of slow progression. A lot has been done in our various countries, but the burden is still increasing. The current prevalence is very high, regardless of the efforts nations are doing. There is a need for community-based approaches that might co-create the solutions that exist today. A lot of researches have been done from the year 2016 to 2023, all the way from South Africa, that has done so well when it comes to community health integrated services, from the health rights studies all the way to surveys that has been done in 2023 by the Kenyan governments that even went ahead to implement the screening abilities of community health practitioners. But this is not working. And so there is, regardless of all this, how well this is implemented is a gap that we need to probe more. Studies are being done. We implement them, we scale them up, but sustainability becomes a challenge. That's why in this study, we wanted to understand what is the status, the current status. And in the study, we are working with the existing community health promoters in Kenya. Because at the end of it all, sustainability, scalability has to be there. And in the Kenyan healthcare system, level 1s are highly implemented by community health promoters. So sustainability is assured in this. So what is the general status of all these? This study was done in 2 sub-counties in Western Kenya. That is Alego Usonga in Siaya County and Seme in Kisumu County. These are 2 counties that are in the Western Kenya along the Lake Victoria Basin. Kenyan side, of course, we have the Lake Basin, more than actually close to 5 East African countries. So this is a study that was done in those 2 sub-counties, and it was a community-based study. Household visits were done, and sample size determination was actually established from the prevalence, the existing prevalence that had been done by Achoka et al. Hypertension prevalence by then was 22, DM diabetes was 3.6. And that's when we did the sample size of close to 254 households. The design was a mixed method, and quantitative data was collected. We used validated tools, WHO validated tools, stepwise approach. Step one, the stepwise approach where interview was done by the CHPs, and then anthropometry, and then biochemistry. This was actually varied a little bit, whereby we did the anthropometry, we did the biochemical check, and then we did the interview, just to suit the setting of the study. I've already emphasized that these tools were actually WHO validated tools that we really used. What were the findings? Sarah County, actually, Sarah County had 53% households, and Kisumu County had 47 households. These are the findings. These are actually socio-demographic characteristics, and more of these were actually 60 years and above, which presented over 40%. More were female than men, and that was a little bit interesting also. And married actually were higher. Formal education, participants with formal education were also more. Many of them come from poor background. And then the assessment on knowledge, practice, and prevention. You know, this is a very hot and interesting topic when you're talking of what do you practice? You practice what you know. What can you prevent? You can only prevent by preventing. You know, you practice, then you prevent. And all this is because the more interest here is about the prevention aspect. More emphasis has been done on, more emphasis is on curative aspect. But how about the prevention aspect? PHC has levels, 1, 2, 3. 1, we have the communities where CHPs are. Then 2 dispensaries, 3, so forth. And so the diagnosis aspect lies with the primary healthcare providers, who in this case are clinical officers. But the CHPs can only make a screening and a referral. Then we realized that when you talk of these NCDs, they know. But when it comes about just listing some of them, they can't even list beyond 3. Out of 10, they can't list beyond 3. And when it comes about practices, very low. So that was a little bit challenging. And this is all about avoid smoking. Many of them were like, fine, they don't practice that. Timely screening, they don't practice that. So that has been a little bit also challenging when it comes to these populations that we as clinical officers attend to. This is where I want to. Out of this analysis of the status, we find that the hypertension in these 2 counties was actually 29.5%. And this, notably, is higher than the current national prevalence of hypertension, which is around 22-23%. But now, this is 29. Diabetes was 3.9, close to 4%, and the current prevalence is 3.6. This shows that the statistics that currently we see from where we practice might not be the true status. So there's need for us clinical officers to go an extra mile to co-create, to understand the populations we serve. What is the status, and what can be the innovative approaches towards that, for that purpose. Then, this is a table that summarizes the whole thing. You know what is hypertension, what is diabetes. They know. Over 70% know these conditions. But listing, only 2% and 1% in these counties were able to list at least 50. At least 50% of these conditions. Out of 10 listed, out of 10 NCDs, they're only 2% were able to list 5. And then when it comes to prevention measures, only 4 and 3% were able to cite the prevention measures you can actually practice. You cannot actually practice. Then when it comes to prevention aspects, only 3% are able to practice. This is on those participants that were actually confirmed hypertension, diabetes patients. So this is very interesting. And this, we do a lot of these outreaches, CMEs, on-job trainings, but the kind of patients we have might not really understand much. And this is the most interesting part, and this is what calls for now the co-creation based on where you serve, where we serve. Conclusions here, based on these findings, is that there's need for co-creation of community-based, knowledge, practices, and need assessment. And when it comes to creating awareness, not the routine way of doing things. So there's a need for co-creation based on the findings. These findings, there's need for community-based and PHC studies to help understand our population's needs and services. What serves better in Botswana might not be the best in Kenya, and what serves best in Gaborone might not be the best in Francistown. So there's also need to have these studies. And I'm emphasizing on co-created studies to help us understand our populations. Then with the e-medicine gaining tract, there's need for digital screening and referral, because this is an area that is less done actually, which is an innovative aspect. Because now e-medicine is like taking over everything. So there's also a need for us to go into this digital screening where this lower level can screen, refer them, the abnormal findings, refer them to us at the PHC levels. Then after seeing these cases, we also refer them back. So there is that continuity of care. And this will be the most innovative thing when it comes to how we handle our patients when it comes to these conditions. Then there's a need for a registry, NCD registry. If we walk around, we'll find that we have cancer registry, which is there, KEMRI, CDC, coming up with them. But to go to diabetes, hypertension registry, these tools that we have in our hospitals, they are not in all level 2s, all level 3s, and they're just shambled and jumbled. We say, I'm improvising this for data purposes. That data is not quality. So there's a need for this registry, a registry that level 1 will use that can, go to level 2, and there's that interaction around that. Recommendations. Having said this, and having said that this is a baseline findings of this project that we run for the next 5 years, then there is need for interventions. There is need for community-based sensitization. This one should at least go digital way because of the e-medicine. Having an app that can be utilized by all these can be a life-saving. Given the fact that the statistics show that over 75%, for instance, over 75% of Kenyans have Android phones, or, have phones, let me say have phones, and have internet. So that means that mobile applications as a co-creation for awarenesses can make the difference than the routine ways of how we've been doing these things. Then training of CHPs. My colleagues in Kenya, there was a directive, an act was done, there was a directive that CHPs, community health promoters, can do screening. And then the question comes, were they trained? And the answer is no. What were they told? On job training. But there is a need for this CHP's training, on this. Having a guideline, NCD guideline, is very core and important here. And these are actually the interventions that the project seeks to address. Then there is an aspect of community-based screening and referral systems. Digital aspect, because of the e-medicine, digital registration and screening can do wonders here as a part of innovations based on these. I think up to that point, I want to acknowledge the IRB bodies, both from Kenya and Belgium, who are actually partners in this study. I want to appreciate GACOPA management for giving me an opportunity to present here, and this is actually one of the core of this project, dissemination. And then I also want to appreciate all the partners. The county governments plays a role. At policy level, when this is done, of course, when interventions are done, then findings are also read and available. Then for policy purposes, county governments will play a role. And so at this point, they played a major role for even giving the approval for the studies to happen in their respective counties. I want to appreciate them. And then MOH, county governments, JOUST, which is my mother university, and VILIR. VILIR is actually a project from the Belgium universities that are supporting this. And up to that point, we have the references, and thank you so much for listening. And I can promise you that in future presentations, we'll have interventions analysis. Thank you.
Okay, so if we have any questions for him, maybe two of them. Okay, we'll start with Mr. Tairu, and then Dr. If anyone wants to ask any question, kindly put up your hand so we see. Okay, you have just two.
Thank you very much for the brilliant presentation. It is clear that the data we see at national level does not necessarily represent what we have at our different country level. My question is in relation to the setting selection. We see that from the results that the prevalence was quite high comparatively to the national data. Was the selection of this setting based on science?
Thank you so much. Yeah, this selection was based on science. Firstly, because of the project, the two counties were purposefully selected because the study is to be in two counties in Western Kenya. So the counties were purposefully selected. Then the sub-counties, the wards and the community units and the linked facilities were randomly selected. So there was multi-stage randomization. Thank you.
Yeah, so you said that we should wait away from the interventional analysis. Give us just two confounders you try to eliminate, since this is like a yearly ruled intervention you want to put on. Because clearly we don't have interventional analysis here. So just two confounders, and how you are very sure that these confounders that you are going to give me will tell me whether we should interpret your suggestions with caution, because already you had 250 people you chose in your randomized sampling. Is that correct? That is correct. So just the two confounders, then we will now know whether we should wait for the next subsequent research before we can interpret your results or your interpretations with caution.
I can combine maybe that question with someone.
Good morning. This is Joshua from Kenya. Okay, in line with the previous presentation, we realize that clinical officers play a major role in as far as the non-communicable diseases. I've tried to go through your presentation and know in any of your bulletin has been able to tell us in terms of employment of the specialized clinical officers, more so those who have done family health, because we realize clinical officers are primary and family health specialists are good at managing these non-communicable diseases. Thank you.
Okay, thank you so much. NCDs are being managed. Just to respond to your first question before I come to his, NCDs in Kenyan healthcare system are actually managed all the way from level 2 upwards, depending on where you are. And that's where clinical officers, most of clinical officers in the outpatient departments interact a lot with these patients. So we realize that this is just a section of the study. This is a section of the study. And there's another part that is based on the facilities. I think that's also addressed at that point. And I know Kisumu County staff are already getting the glimpse of the same. So we realize that there's higher prevalence of these participants to go to the PHC facilities. But at these levels also we have some other challenges that are system-based. So those are some of the things that will be addressed in the other levels. Then, on the confounding, it is very interesting. It is very interesting, but maybe as we move forward, because this was just a baseline findings, but as we move forward, that will be addressed into the studies as we implement the interventions. Thank you. Thank you so much for listening.
Another question. Hello? Hello? I have a question. When you began, you said that the health, community health promoters are not trained as yet. And then they are also given the system to use when they are trying to report or whatever they carry out their investigations in the community. My finding with that is that once they take a PP, it will, if it is a little bit high, it will go direct to the system of Kenya as being high. And if these people are not even trained, it's on-job training, how are we sure that the sugars that they are doing in the community are really the readings as per what we expect? So, and also, when you go to the system of Kenya, you will find that their readings are quite high. But when you come to the facilities, those people have not been referred to the facility. So how do you put that together so that you can give us a picture as this is what is in this community and this is how we have managed it? There is a pickup, I think.
Thank you so much, my colleague. Actually, that is, you've actually summarized the gap. You've summarized the gap that was existing. And there's a need for that communication between all the levels. And so digital system as an intervention is now will now address that gap that you've just stated. But your observations are actually true of the existing gap that the intervention will address. Thank you so much.
Thank you so much, presenter. My name is Doreen Nalugwa from Uganda. I want to add something on to what my colleague has said. Like she mentioned, these people were not trained. We want to understand the kind of people who were picking these blood pressure levels, taking off the sugars from the community, because you earlier on mentioned, like she said, they were not trained. Then how do we rely on your 29.9% to generalize that hypertension is really higher in these two counties against the national prevalence? Thank you.
Okay.
In other words, how should we rely on it to generalize and say it's higher?
Thank you so much. The outright response is yes. Why? The CHPs are actually, for this study, they were recruited, trained purposely for this research. So that means that we actually achieved that in the first place. Then the findings now brings us closer to the training aspect for the purposes of strengthening, implementation, scaling up, and sustainability. Thank you.
Thank you very much. I believe those are all the questions.
So this is a research in our PhDs. All research should follow one philosophy, no matter the particular discipline. So when I sit here, even if it is in the humanities you are conducting a research, it follows one line. So likewise, if you are doing the same research in the health field, it follows one line. So that was the question I asked. That looking at your data, I don't know which biostatistician you use to employ it, but looking at your data, trying to generalize your hypothesis to include or to ascertain the fact that it's a reflection of all that is happening in other counties might be something we might interpret with caution. That is why I first said I wanted to know two of your confounders, but you said that it is a progressing research which you swayed the question. So in actually generalizing this your research, we have to take two things in account. Have we eliminated all the confounders? And is our population a true reflection that we can use those two counties? I understand the fact that you use a randomized sampling method in these two counties, and you purposely selected the people and whatever you want to go on. But we would want to see the next phase of your research before we can come to a judgment whether we can generalize looking at your population sample.
Thank you.
Any other question? Okay, so thank you very much, Mr. Sylvester Ogutu. This actually sounded like a thesis defense. Yes. So that actually tells you that there are a lot of learned people here who scrutinize everything you mount here to say. So please, those of you coming after Sylvester, take caution. We'll be asking confounders and all the other ones. So please, yes, that's just right. Please put your hands together for him. That's actually a very good presentation. Our next presenter is Mr. Scott Smalley. Please, let's receive the president of IAPA as he presents his abstract.
Good morning to my colleagues from around the globe. Good morning to the colleagues from north, south, east, and west. We are together. Are we not together? We are together. Sambanani as a welcome in the language of South Africa, where I'm coming from. And before that, I come from the United States. Very happy to be present here. amongst all my colleagues and friends, and I'm very happy to provide you with this systematic review, study, findings, results, and discussion that I did with colleagues from the United States. These are PAs from the United States, and I really want to acknowledge the authors Arden, Jane, Rachel, Candy, and Kimberly, co-authors, all females, all very strong in their clinical work and education, which I'm very proud of. I'm the only male in this group here. And this was work that we did through the South College of Tennessee, so I want to acknowledge them, a physician assistant program there. It was part of their research for their capstone final project, and we're really pleased that we submitted this to the Journal of the American Academy of Physician Associates, and they've accepted this for publication in the November issue. And I encourage all of us to do research. I encourage all of us to submit. I'm going to share today about how to do a systematic review, a very nice, straightforward process where we can really catalog, gather information of what's in the literature around a topic of interest. Our topic here is to catalog the physician associate, clinical officer, and comparables, the equivalent practitioners around the world, using the lens of public health. How do we contribute to public health? How do we contribute to global health? And I'll do some focus on Africa here. I'm so delighted, again, to share with these colleagues. These are photos that have been happening throughout this conference. And we want to just review what I discussed yesterday, is the International Labor Organization recognizes our profession under the category of paramedical practitioners. Paramedical, para being with, and medical with the medical society. So we are with the medical society. It's often confusing because a paramedic is someone who rides in the ambulance. And of course, that's pre-hospital work. Some of us do pre-hospital work, but many of us are working in the clinics, in the hospitals, in tertiary areas, all areas of medicine. We're not just simply a paramedic. So we have proposed to ILO for a name change. And there's a PA-CO working group. Many of us in the room over many years have been submitting to ILO. And we are proposing the clinical practitioner global term. I'll talk more about that coming up. I shared this definition from the ILO of what is the tasks of a clinical associate, clinical officer, physician associate, medical assistant, or clinical practitioner. So in red, we advise, diagnose, we provide curative and preventative medical services. I really liked that yesterday. Dr. Ingero said these are the four main areas that we work on. We expand outward. Many of us are autonomous, but some of us are supervised, and sometimes that provides limitations for us. In this study, we looked at the literature. What are the benefits? What are the limits? That's a big limit for us when there is supervision. Sometimes that supervision is required by law, but the people on the ground are not available to supervise us, so we're often left on our own to make these decisions. I think an important part, though, of our training is we are trained to make clinical decisions. That distinguishes us from others, such as a community health worker, sometimes we're confused with, who follow protocols. But we are trained to make clinical decisions, to diagnose, to prescribe. Okay, now when you review the literature, there is not one substantial catalog of every country where we exist, and of our education, and of our clinical practice, our scope of practice, our regulations or certifications. So this was the aim of this, to take a global health lens, try to catalog all of the countries where we exist. Currently, much of the literature calls us what we're not: non-physician, auxiliary health provider, mid-level health provider. In many countries, we are the frontline health provider. We're not mid-level, but at the front. So we really want to put out a huge catalog of what we are, so that everyone in policy and government can understand us. We talked about no accepted name, but we are currently on the cusp of proposing clinical practitioner. We don't have common scope of practice or even a template for what a global scope of practice could look like. We really need to inventory our health profession. Okay, so the objectives of this systematic review is to provide insights how PAs and equivalents address global health needs. To aid in the globalization, we want to catalog, we want to identify. We also want to assist in the understanding of us, where we work, how we work, and we want to hopefully increase the adoption of our profession in many other countries, and certainly support the countries that are struggling. So a systematic review, we follow the PRISMA 2020 guidelines. These are very straightforward processes for research. It makes it that it's very solid in what you do. We had 6 databases where we input our search terms. Once we input the search terms, we pull out the different articles, the different literature, and we decide if it's appropriate or not. We do an quality assessment. We use the National Health Library of Indices for this. We also had ethics approval through the college. And we did a mixed method study where we had global experts join us. So we used the literature as well as 9 global experts. We confirmed the information in those 2 areas. This led us to do data extraction tools of all of the literature and the expert opinion we found, as well as develop themes. And from that, we were able to make recommendations. So when you're doing a systematic review, you develop many search terms. We had 23 search terms to be very broad, so we could catch many articles, literature. And then we also had to put in a definition of what we were looking for, so that we can include articles or exclude articles. And this is part of your systematic review process. So we use this definition. We combined several definitions from WHO, ILO. We also realized that we needed to advance the definition. So I'd just like to read this. And I think this is something that we could use for our profession. GACOPA, IEPAE could adopt this. A PA or PO equivalent is a clinical practitioner with a minimum of 2 to 5 years post-secondary medical education, who is trained under the medical model with clinical decision-making, acting autonomously or with limited supervision with the healthcare team. The scope includes diagnosis, treatment, therapeutic procedures, minor surgeries, prescribing medications, and working in primary healthcare and specialty disciplines per their education, training, and experience in the context of that healthcare system. And I think this is important. Education, training, experience in the context of the healthcare system, because many of us will be fit for purpose or will fill gaps that are needed in those countries. So as you do a systematic review, you then move through a huge collection of what meets the initial criteria, and then you have to eliminate articles that don't quite meet your inclusion criteria. We started with 818 articles. We eventually came down to 538 sources that matched our inclusion criteria. These now fit our definition and work within global healthcare needs provided by the PA equivalents. Primary outcomes, we found out the geographic regions where they exist. I've shared some of that and I'll share more. The economic status of the countries where they work, as well as the healthcare needs of those countries and what they're providing, and about the healthcare system where they work. Secondary outcomes, evidence of PAs in that country, whether they volunteer or whether they're educated, whether they're trained, whether they're being considered, or whether they used to exist and reasons they stopped, and how they alleviate public health needs, and the regulatory of the profession, the education of the profession, as well as any barriers faced for implementation so we could learn for these lessons. A global map of where we exist. This literature found 68 countries where we exist. That is 63 proper countries and 5 US territories. 68 countries the literature showed. I shared yesterday, I've gone more and done more of a desk analysis, a desk review on the computer, and I found in additional countries up to 80 countries. I hope to publish that coming up next. So we're continually finding more countries where it exists. And I think someone on the panel said, you know, we are probably in almost every country. We just haven't reached out to them to contact them yet. This slide I shared, we were finding that we have 35 different practice titles around the globe. 35 different practice titles. The most common being the PA, and the second most common being the clinical officer, and then many other professional titles. Some of them are based on the context where they develop, some of them based on the language. It's interesting how these names developed. And the names can be really important. It is what identifies us, but the names could also prevent us. We've learned in Botswana that the Health Professions Bill identifies clinical officers for employment. However, the college here graduates them as doctor assistants. And so the difference of the name is right now limiting them from being registered. We need to identify that our names are similar so we can be registered. Now, I've been sharing with you the PA working group is talking with Laura, the ILO representative, about our proposal for a global term and a definition. I received an email yesterday during our conference in response to our submission. And they are recommending that we use the term physician associate as the global term. She is saying is that the committee was unfamiliar with the clinical practitioner and that this term was not in other countries because this is a statistical process. Statisticians receive the ILO request to identify how many of their employees with that title are in their country. And she is saying the statisticians would not be familiar with clinical practitioner. Therefore, she would get very little results. Now, I'm not sure I agree with that. I think that we would need to market and explain clinical practitioner. And we would have to explain clinical practitioner is the term that identifies those practitioners in your country with any one of the 35 names, one of them being PAs. I don't feel that physician associate should be the global term. I think that we should have a global term which is broad of all of us, such as clinical practitioner, which then lists our 35 unique practices. But I just want to make you aware of the conversation that's happening so we can continue as a collective to put forward what we feel should be our global title. We should decide what that should be. Now, we found that many of these practitioners working under the developing countries, 45 countries have PAs, clinical officers in developing countries. 15 of those countries are developed, and then 2 of them are in transition. We found that most of the public health needs is to relieve healthcare shortages. We learned that there needs 45 million new healthcare workers in the world to help take care of the 8 billion people that we have. And PAs and clinical officers are really excellent at filling healthcare shortages. Next, we can see that most of the work we do here in Africa is around primary healthcare. We are the frontline providers, and certainly in pandemics that unfortunately affect this region perhaps more than others, environmental factors. Global climate change is real, and health crisis is happening due to climate change. Many persons in Africa are really unequally affected by this climate change, and so our practitioners are really doing good work in this area. We found under healthcare systems, most of our practitioners work under the national health insurance schemes, or where the government is providing healthcare for the citizens. Many of us work in the government hospitals, the government clinics, particularly in countries of Africa. You can see we also next work mostly out of pocket, where citizens would have to pay for their own health care. And then we have other various healthcare systems, Belvidere, Bismarck, these are some, and also in mixed. Here in Africa, as we focus on it, we're looking at alleviating healthcare shortages, economic disparities, and as I said earlier, pandemics. And much of this is through task shifting and task sharing. I think you've heard of this term coined by WHO and others, where we as healthcare teams can really share in the work. There are too many patients to go around for the persons that we have. Each of us have our unique skills that we can lend to the team. So much of the work in Africa is around task shifting and around task sharing. But we are limited by our recognition. We are limited by our laws. We are limited by lack of standardization, as we've been discussing. And these are areas we certainly need to jump on and really improve as a collective. I shared some of this history yesterday. This is focusing just on Africa. I mean, we can be really proud. 31 countries in Africa have our clinical practitioner, as early as 1896 in Malawi, all the way up as recently as our hosts in Botswana. There's a lot of literature documenting task shifting and task sharing for our health profession, and I want to point out that there are multiple catalogs that have been done, and we're looking at the different countries. Our catalog that we've just about to publish has the most countries in collective. Now, there is a WHO workforce report that came out, and I'm really pleased that Dr. Manesh Bocha was an author of this, of Chapter 9, put out in 2002. And they did an excellent cataloging, which much of our literature comes from. There are others that have done work in 2020. You can see earlier, 2013, WHO. One of the main ones that was done was Brown et al., WHO, calling us mid-level health providers in 2010. And then here in Africa, Mullen and Fitzhugh did an excellent cataloging of 47 countries in South Africa, in Africa, which did include at the time South Africa and many countries that are represented here. But you can see many of these are old, so we need current research to look at this, and we're hoping our systematic review can be the new white paper for cataloging us. Now, some of the literature shows excellent work. In Uganda, medical clinical officers are doing over 500 surgeries per year. In Tanzania, 80% of all C-sections done by clinical officers, obstetric hysterectomies, laparotomies. In Mozambique, a study found técnico de Surios, that is the Portuguese name for our profession, can do decision-making, quality of care, comparable to obstetricians. And in South Africa, studies show over 1,500 volunteer medical circumcisions are being performed by clinical officers. The backbone of that surgery is our clinical officers, clinical associates in South Africa. I just want to focus a bit on South Africa. This is where I have been a lecturer and the head of the division for 6 years, and I started my lecturing in 2010 to help implement the curriculum. And we borrowed much of the curriculum from East Africa. Really, clinical officers are really leading the way here. We brought this into the University of Witwatersrand, the University of Pretoria, and the University and Walter Sisulu University. We've been in existence for 15 years, and we've now graduated 1,758 students. Of those, 1,400 are registered. So you can see 358 are not registered. Some of that is due to finances. Some of that is due to deciding that they want to do another profession because of lack of posts. Some of that is they've moved into more advanced studies, different reasons that they're leaving profession. But those numbers match other professions. It is important that we benchmark against other professions when we look at these studies and numbers. Our scope of practice was passed in 2016. That was 6 years after the first graduates were actually working. So for 6 years, they didn't have a scope of practice, which made it very challenging. Our scope of practice in South Africa is quite broad. It says that a clinical associate can perform any medical act delegated to them by their supervising physician, in line with their education, training, and experience. So what you learn in the university is your scope. What you then learn when you're in your internship and in clinical training is your scope of practice. What you learn on the job through continuing medical education, continuing professional development is your scope of practice. What you are trained with your supervising physician becomes your scope of practice. As medicine grows, it becomes your scope of practice. We are employed by the government, by private NGOs, and in research, also academia. However, there is really limited posts in the government. We had strong support from our health minister in 2005 to 2007, and then we had a new health minister who was very doctor-centric, and so there was less focus on other health professionals in the area. And we really were limited in our posts. Bursaries that provided education, 3 years of training, and then 3 years of employment back in their province, all dried up. We've been trying really hard to gain momentum again in the country. We had a new health minister who was supportive of us, but now currently the old health minister has returned. So much of politics influences our ability to practice. You know, we've been recognizing throughout the discussion. I think we've been talking about how politicians are so important for us to make collaborative efforts and to work together. You know, we thank you that so many are here today supporting us. We also have a lack of prescription rights. The law in South Africa does not recognize clinical associates. You know, so it's an important lesson for all of us. When we start a profession in the country, we really need to be sure that we're going through the process of making sure all doors are open. We missed changing the law for prescriptions. It was an oversight. And now it's very difficult to go back and try to change that law. I think we really need to follow our Kenyan brothers and sisters. They do an excellent job of making sure that the laws are all laid out for different areas. I am so impressed by the scheme of service that's been done by what's happening in Kenya. Uganda also has a scheme of service that's been developed, very similar to that. When I travel through Africa, other countries have that, and that's the biggest take-home message I brought to our South African delegation. South Africa needs to develop a scheme of service. Okay, here's some numbers of where we work. So I said that the posts in the government have started to dry up. You can see on the left as working in the public. Over the years from 2016, the numbers have really gone down. Whereas the next one is working private. Those numbers are going up. Private is seeing the benefit of clinical associates, and they are hiring them. They are seeing many different areas where they can work. This is really putting pressure on the government to start developing posts. And I'm so pleased to see we're moving into research, education, so we're educating our students. Now we can be role models in the clinical areas for our students. There are quite a few that are not working clinically. Some of them are going into law. Some of them are going into business. Some of them are taking their health degree and they're adding something else. We heard the other day of the importance of combining those so that we can really be advanced within our own country. Many of these clinical associates have a business degree and they're helping us develop different business medical products. Where we're located, over 50% are in primary health care, and that includes in family medicine, that includes the emergency department, and that includes the outpatient department. But we are in South Africa moving into other specialty areas, so we're becoming more advanced in anesthesia or surgery, pediatrics, or obstetrics. And the University of Witwatersrand has started an honors in emergency medicine. That was a need in the country. I shared yesterday, there's a lot of violence and trauma in South Africa, so our clinical associates can do really well there in emergency medicine. There are over 45 studies about clinical associates in South Africa, and one of my colleagues, Sanelli, Dr. Nkobo, has just done a systematic review of those in South Africa. That would be a great study for you to do in your country, is systematic review of all the articles of your country's clinical practitioners. So under this one article that comes out from that is 45 supervisors were evaluated for their opinions of clinical associates being able to perform under direct supervision, and they strongly agreed or being able to identify themselves as clinical associates, and they strongly agreed. Because sometimes others will say, oh, you're a doctor, or oh, you're a nurse. And we say, no, we introduce ourselves as a clinical associate, and here's what we can perform. They also said that clinical associates were very ethically guided. Our previous speaker said how important ethics is in healthcare practice. So this study really showed the positive outcomes of clinical associates over 15 years. The study further asked, do you think they contribute in these areas of medicine? And overwhelmingly, you can see more than 90% positive response, saying that they support HIV, non-communicable diseases. Our last speaker just spoke about that. Increase in increase in hypertension and diabetes. In tuberculosis, 95% of the supervisors agree that we contribute in this area and help make a difference. Okay, you can see down below in maternal health care, that's areas where we need to do more work. This can help inform our curriculum for more education in that area. It can help inform more clinical practice for supporting our obstetricians for clinical associate improvements. I'm coming to the end now. Our systematic review looked at all the different associations around the world that support clinical officers and PAs, more than 61 different associations. I hope you find your country's association name here, your union name here. We want to be sure that we get everyone involved. As part of IEPAE, we sent out our welcome invitation to our quarterly education meetings, and all of us are on the list. We send out invites to our IEPA conference we're having in Lynchburg, Virginia. All of these are on the list. If you're not on the list, please let me know. It's so important that GACOPA, IEPA, brings together all of our different educators, all of our different associations, all of our different unions to come together for us to be one voice. And also, please become a member. Please be a paying member of your local association and your global association. Without your funds, it's not possible for us to do the things that we are working on collectively. I just became a member of GACOPA today. And I hope every year to continue as a member of GACOPA. So recommendations from our systematic review is we really need to continue to increase our collaboration. And we need to continue these conferences. We need to continue with our regional conferences and, of course, our country conferences. We really need to support GACOPA, IEPAE, the European Network of PA Educators is a regional organization, the PAs for Global Health. We also had for a long time the African Network of Clinical Practitioners. We really need to pick that up for all of us here within Africa. I know GACOPA is working on chapters of different regions. This is a way for us to connect. We need the guidelines for licensing across borders. We talked about this many times. If we have a template for a scope of practice, that will really help us. And then also, IEPA is working with GACOPA on our education framework. So through Loop, I've talked about that, we are getting curriculum around the world of all of our PAs and clinical officers. We can propose accreditation standards. This will help tremendously. Continue our ongoing dialogue. It will only lead to improved outcomes, innovation, job opportunities, increase in access and delivery. I really thank you for allowing me to share on this study. Open for any questions. Testing? Testing? There's a question here on the right. Let me bring this mic to you. I think I'm now becoming the MC, which is fine.
Thank you. Good morning. I'm Bonto Waniwa, 5 years graduate, but unlicensed from the Republic of Botswana, staying in Francistown. Since yesterday, I've been watching some presentation or discussions. It seems most clinical officers or PAs, they lean mostly into consultation and pediatrics, all those. A few of those are into surgery. I wanted to understand if is there any influence that leads us to be leaning more into clinical medicine or consultation than surgery. Thank you.
Okay, I think I'm seeing the question is around that our main training is in primary health care, consultations, physical exams, making initial diagnoses. And where we have the expertise, we can then make the management plan and treatments. And where we're not able to, where it maybe goes outside our scope of practice, we can then refer. refer to the specialist. But also many clinical practitioners are moving beyond common primary healthcare conditions and are moving into specialties. And then where those governments support that, or where the healthcare system supports that, many of them are moving into areas of anesthesia, into surgery, into pediatrics, into obstetrics, into ophthalmology, into ENT. Yes. So I think the question was, how do we support that, or why is that happening? Both.
The question is why?
Why? Okay, that's a great question. Now, why would that be happening is, okay, one, there could be just an interest in advancement of that individual into other areas of medicine, and so that they want to further their studies, and in furthering their studies, they might go into a specialty that's available, and they have a keen interest then to support that type of patient profile. Another might be that they're not able to find a job in that primary training that they have of common conditions, and that jobs might only be available in that country in specialty areas. We've seen that in some places. However, that can be a limit for some of our practitioners who in that country have not yet set up a specialty education track for them. Okay.
Thank you. We have a question here.
Mine is not a question, but I think it's something I should insist, because it's something I said yesterday. Before we talk of individual membership in the global GACOPA, it's my view, or in my view, I think it's better we first start, because in your second to last presentation, you showed us we have about 61 associations. Can we have these associations registered first in GACOPA? Because it's the same associations that in our respective countries we are in, we are subscribers. Before we talk of individual membership in GACOPA, can we have these associations in different countries, from different countries, get registered in GACOPA, they effectively subscribe to GACOPA, so that they strengthen GACOPA before we come to individual membership in GACOPA? Thank you.
Okay, it's a very nice comment, and I think those discussions are happening, and I hope there is space where we can discuss that today. We could turn to the GACOPA president in a moment. As the IAPA president, we do honor institutional memberships, and therefore members of that institution can then be members of IAPA, and we're working to see how we can expand that further. We're working on different regional chapters where then those associations in that region could be part of that. I really like this idea, and I think it needs to be discussed and looked at. There is also the key that finances are important to run the organization. So we also need to think about that. How can the associations, through their membership, provide some type of financial support to IAPA or GACOPA, which would include those members broadly. I really like that idea. Thank you for that comment.
Mine are just two concerns. One of the concerns is about the statement that ILO has sent to your mail about them recognizing us as physician associates and not wanting to go by the rule of the people. I think where you stand as Mr. Smalley, you have a very good chance of advising, because I believe even the laws are made by people. So if they pick the name for us and we have chosen to be called clinical practitioners,
script. They can write the script and they can write to the medicine and instructions, but then their supervisor needs to co-sign. Or the clinical manager of the hospital has to have a blanket letter in the pharmacy saying that the following clinical associates are employed here, they are with the scope of practice to prescribe, I will co-sign for them. And there needs to be that agreement. Yeah. So there is a way for us to help our patients with prescriptions, but it is a little bit of a hand-tying process. So we are now going to the South African Pharmacy Review Board so that we can acknowledge clinical associates as prescribers, so they can then support to the Minister of Health, so we can draft new legislation so they will prescribe. We're hoping within 2-3 years this law can change.
Okay, I think there's no more question. Okay, there's one here.
Good morning once again, Scott. I think this is a matter that I've been following up with you over a number of years now. We can see just from the association that exists to say there is nothing that is unifying us as clinical officers. What has really been the difficult part in terms of coming up with a common name? Just within Africa, you can see some discrepancies. Come to our country where I'm coming from, we've got two, of course, that are existing already. So we've got clinical officers and we've got a medical licentiate. And thank God, anyway, through the government, the current government, like I said, to say political input is always important when you know where to step in. Can't we really look at it critically, like in the way our nurses are operating? I stated it yesterday to say, regardless of the qualification that you need to have, we should be considering the level and we maintain the name as clinical officer. If we are, as Africans, can start it from there, I think it can help us to work everywhere and be able to reach the levels that we intend to reach. Our counterparts, I think, Botswana, I really participated in one of the curriculum review that they had brought to Zambia through the council, in which, of course, we have already considered what would be our salary if we maintain the name of the clinical officer. Hence, we go on to standardize creating our own names like medical assistant. For how long are we going to continue assisting people? Our law is primary health care. We are not there as assistant. So let us focus, what does primary health care intends to bring on the floor? Primary health care, we know to say, it is in the far-fetched areas where doctors are not there. Primary health care, it is in these underprivileged areas where we come from. Primary health care is within the communities in these urban areas in which these hospitals are existing, in which these clinics are existing. And we have already shown them the purpose. That one, we are level-headed in terms of one, the knowledge. Two, we are level-headed in terms of the skills. Three, we have showed them to say we are level-headed in terms of what? Our attitude as well. So let us have a mindset that is going to transition ourselves. And that mindset, of course, it is going to start within ourselves, within our region as Africans. But if within our Africans we think we are more educated now, we don't need this title because of remunerations, it means we are not going anywhere. So Africa clinical officers must rethink again and come up with a better strategy that is going to help us to grow. I submit.
Thank you. Thank you very much. I think that one forms the last part of the question. And mine was about, according to the statistics, we found that in South Africa, most of the clinical officers, a number of them are doing CSs. Although in a questionnaire regarding the input of clinical officers' impact in reproductive health, we saw not a very good percentage agreeing that clinical officers have an impact. Maybe I don't know the disparity, but I think you might have reasons to that.
Okay, thank you. Yes, in the clinical associate curriculum, we teach maternal health in our second year, and then they go into maternal health wards and obstetric wards and gynecological wards and support patients, also through OPD or emergency department treating those conditions. And during our 3-year curriculum, it's not a requirement to learn cesarean section, but it may be something that they would participate in once they graduate. And if they're learning under their supervisors of C-sections, then they can be taught that, and like our scope says, that can be incorporated in their practice. So part of the reason I think the numbers are so low about maternal contribution is because that particular area is not as full in our curriculum. I mean, we do focus a lot on the primary healthcare aspect, and you saw 50% of the clinicians are in primary healthcare areas. If it's something that the country feels we need more of, which there is some discussion around that, then in South Africa we would set up an honors course. After our 3-year bachelor's degree, we could then have an honors in maternal health. And during that curriculum, train them in areas that are really important to then come out and make an impact. And then I think those numbers would come up. Other countries really saw that as a need. I mean, that was part of Zimbabwe's push to take nurses and midwife nurses specifically and train them up in a 2-year program of clinical officer training so that they were really proficient in cesarean sections. And then from that, able to reduce maternal mortality. The same in Ethiopia. They trained up the integrated surgical emergency officers. The same in Mozambique. One study I was showing you there about the surgicos, the surgeon technicians that they trained up there. So in South Africa, that has not been as much of our focus. And maybe that's reflecting in the numbers.
Oh, thank you so much. I think the next thing is we be upstanding to give Scott a round of applause. You know, he's our hybrid in the room. Let us be upstanding kindly. Let us be upstanding. Thank you, thank you, thank you. Thank you, thank you, thank you. Thank you very much for the presentation, Scott. It was very nice and very encouraging. Thank you.
Please don't sit. We all move out for breakfast. Yes. Yes, breakfast. Yes, breakfast. Let's go. Tea break. Okay. I've reframed it. We are going out for tea break. But it is breakfast. All right. We didn't start early, so we couldn't have had breakfast before coming here. That's why. So, tea break, breakfast, whatever I choose to call it, we are going to eat.